Welcome, everyone. I'm Dr. Jess Heron, Chief Executive of Action on Postpartum Psychosis. Thank you so much for joining us today for our lunchtime webinar in collaboration with the National Centre for Mental Health at Cardiff University and GPs Championing Perinatal Care, the GPCPC. This will be the third in our series of annual webinars delivered in memory of Alex Baish. The aim of the webinar is to draw together key knowledge for health professionals to make birth safer for people who experience postpartum psychosis. In total, nearly 6,500 health professionals have joined the previous two webinars, and they've been watched back on YouTube over 4,000 times. We've got nearly 3,000 professionals registered today. Over 448 feedback surveys, 100 people who watched this webinar say it will change their practice. So today we'll hear from Richard Baish, APP's Bereaved Families Coordinator, about what he hopes we can change with this webinar series. APP Diverse Communities Outreach Coordinator Shahida Akhtar will share her experience of postpartum psychosis, highlighting missed opportunities. Dr. Rock Campwell, retired perinatal psychiatrist and advisor on perinatal mental health to the Scottish Government, will update us on learning from the confidential inquiries into maternal deaths. Dr. Sally Wilson, National Training Lead for APP, will talk about signs and symptoms and getting the right help for your patient. Professor Ian Jones, Professor of Psychiatry and leading PP academic, will share knowledge about identifying and managing those at high risk of postpartum psychosis. And finally, Alison Jordan, Chief Executive of Pete's Dragons, will outline practical tips for asking about suicidal intent and the things that we can all do to support our patients alongside appropriate referral. As we won't have time for questions in the hour, we'll put together a Q&A podcast and send it as a resource after the webinar. So please do submit your questions to the panel using the Q&A function at the bottom of the screen. We'll post resources as they're mentioned by the speakers in the chat, and the chat function will only be opened up for comments and chat after the end of the final speaker. We know this can be a difficult topic for many people. It is being recorded today, so if it's not the right time to be watching for you, please take care. We'll send out the recording so there will be other opportunities to watch. If you have personal experience of PP, there are peer supporters available all day online on the APP forum. The link is in the chat now. The peers are there to talk if you need to, or just drop in and say hello and introduce yourself. So I'd like to warmly thank Richard, his family, friends, and everyone who supported him for making this webinar series possible. I'll now hand over to Richard to tell you more.
Thank you, Jess, and thank you everyone for giving up your Wednesday lunchtime for being here today. They say that there's a saying that people die twice. They die once in real life, and they die once when people say their name for the last time. On 24th of October 2022, my wife Alex took her own life after suffering with postpartum psychosis a month to the day after giving birth to our second child. She had no history of mental illness, nor were there any significant issues affecting us or her after our first child. After her funeral, I vowed publicly that I would turn her passing into more of a positive than a negative. This will never be the case to me and my family, who will always bear the scars of what happened. However, from a societal point of view, almost 3 years later, we're able to continue Alex's legacy. This is why we're all here today, because of Alex, and to make sure that she lives on beyond her death. It's hard, but I try not to think of Alex taking her life. Instead, I try and think of it as giving her life to allow others to heed the warnings. So again, thank you. Alex's birth to our second child, Rosie, was as smooth and as quick as it can be. For the first couple of weeks, we reached something resembling a halcyon period as a family. Over the coming days, feeding and sleep both became more challenging. Everything intensified 4 weeks after the birth. Alex told me as soon as I walked in through the door one day that she wasn't well. She'd become extremely anxious, and she'd told me how everything felt exhausting, how she was worried about how we'd be able to function. I didn't really know what to do or say except to listen and do what I could with Rosie and speak to Alex's mum. I slept next to Rosie that night to Alex catch up on some sleep in the next room. We made the decision to stop breastfeeding and move to formula so I could help with the feeding. Alex had a look on her face the whole time which I'd never seen before. It was like she was full of a mixture of torture, sadness and despair, combined with a determination, and yet somehow at the same time she seemed completely vacant. Unlike many cases of PP, she was more withdrawn, and it was harder to spot than that she was in immediate danger. We knew something wasn't right with her though, and the next day Alex and her mum visited the GP while I stayed with our son. The GP booked her into a mental health professional that week and prescribed antidepressants, which would take around 2 weeks to get to take effect. She took her own life that night. Having to sit down with Freddie, then age 3, and having to explain to him that his mummy's died after he asked where his mummy's gone is something no parent should ever have to do. Watching him have to correct strangers when they talk to him and refer to his mum that my mummy's died is something no toddler should ever have to do. One of the most heartbreaking things about this is that this tragic story could and should have been avoided. There needed to have been some kind of intervention from someone at some point on our journey because postpartum psychosis is a treatable condition. With the correct support and intervention, the vast majority of mums recover from it. And that's why we're here. If people come away from today being aware of what PP is, what it might look like, how to treat it with suitable provision, it's a fantastic use of an hour on a Wednesday lunchtime. I've learned a lot in the past 3 years. I now know that postpartum psychosis is a psychiatric emergency. I've learned that there also exists a chance of a relapse and that PP can have a long-term effect on a mum and her family. I've also learned that while it takes a village to raise a child, it also takes a village to get a family back on its feet. And I'll always be so grateful to so many people around me over the last 3 years. I've learned that there are some fantastic people in this country leading the way in terms of research and training, and the future is bright. It's been a privilege to have joined the phenomenal APP team in January, and with funding from the Department of Health and Social Care, we've been able to develop resources to support bereaved families, which can be found on APP's website. Although the circumstances of our paths crossing are obviously heartbreaking, it's felt heartening to learn that I'm not alone, that tragically there are other people in this situation too, all of whom are either on the road to recovery themselves or are keen to help others by finding a purpose to their grief. I liken what my family have been through to climate change. No matter how many news stories you see about floods or forest fires across the world, there's largely a feeling amongst people that it won't happen to me. Until your house burns down, you probably won't take the risk that seriously. This was my house burning down, and I knew nothing about the cause until it was too late. Today is your chance to make sure that no one's house burns down if someone you encounter suffers with PP. Thank you so much again for being here today. I hope you find the next hour useful. I'm sure you will. I'm going to pass over to Shahida.
Hi everyone, my name's Shahida. I'm a peer support facilitator for APP and I work on the Diverse Communities Outreach Project. I experienced postpartum psychosis in December 2018 after the birth of my daughter. Like so many women, I had no prior history of mental ill health, and also like so many women and families, I had no knowledge of what postpartum psychosis was. I'd spent a significant few days in hospital without any rest, without any sleep. After she arrived, I found myself up on the ward at midnight, completely exhausted, tired, and just completely emotionally overwhelmed. And that's when my breastfeeding struggles also started immediately. I really struggled to breastfeed. I wasn't producing enough milk. I couldn't get baby to latch. And it all just weighed really heavy on me. I spent a further 2 nights in hospital after she was born. Really awful emotional time. I was crying my eyes out, saying I couldn't cope. To be honest, I think that was probably one of the first moments that perhaps someone could have noticed that things weren't quite okay with me. And then a couple of days after we got home, I actually came back into hospital for a routine checkup. Again, I hadn't been sleeping, hadn't been resting. My eyes actually looked like golf balls. But I went into the nurse's room, and it was then that I actually started burst into tears. It was just too much, and I started crying. And then she asked me what was wrong, and I told her I was struggling to breastfeed. I was finding it really difficult again. At the same time, I was trying to express milk, and I wasn't even able to express enough. I always say this is the straw that broke the camel's back, and I started to feel like a complete and utter failure. I was a rubbish mum. I couldn't do anything. I couldn't feed her. And that's when all the other symptoms really kicked in. I was getting confused over tiny little things, started to become really paranoid and scared. I thought I was being hounded by evil spirits. I was obsessed with cleanliness. I was obsessed with prayer. I was reciting verses from the Quran and blowing on myself for protection. I was playing the Quran nonstop in my house. That kind of snowballed into thinking that I had a special mission. I had special powers. I had to protect my daughter. I was in danger. My daughter was in danger. And then I had my very first episode a few days later in bed. My husband gave me a piece of sweet to eat and I put it in my mouth and it felt like super glue. I couldn't chew, I couldn't swallow, I couldn't breathe. I started having a panic attack thinking somebody was trying to poison me. And then I don't remember quite what happened. The next thing I remember is I'm suddenly surrounded by my mum and my brothers, and I'd almost blacked out. And I looked down at my wrists, so it looked like I'd had to be restrained. And then I thought I was dying. Then I was really scared. And I said to my brother, please don't call the paramedics out. I don't want to go into hospital, because I thought they were going to separate me from my baby. But they did call the paramedics out. But by the time they got to the house, I was coherent and lucid again, and I was talking fine. My vitals were fine, and I refused to go in, and they didn't take me in. The next thing I know, I think it was in the next few hours, I was in the back of an ambulance, and I couldn't remember how I got there. And they took me into the A&E. They did an assessment. But again, by then, I was completely coherent, speaking normally, and I managed to talk my way out of being admitted, and they gave me some kind of sleeping medication and sent me home. Not being able to sleep then snowballed into thinking that I didn't need to sleep, and I was firing on all cylinders. I then had this idea that the devil was trying to get into my head to extract this special information that I had because I was special. I then just became progressively worse at home. There were moments where I'd be okay, and then there were moments where my behaviour just became more erratic, to the point where I ended up having a huge episode in my doctor's surgery. We actually went in for an appointment for my daughter, and I was demanding to see my own GP. And I remember him walking in, taking one look at me and saying, oh my goodness, she is really unwell and we need to get her some help. That was on a Friday. He referred me to the mental health services on the Friday. By the Monday, when my health visitor and my midwife came to see me, I was rolling around on the floor, talking absolute nonsense. They took one look at me and said, she needs to be admitted today. So I ended up being sectioned under the Mental Health Act, and I was admitted to a general psychiatric ward. Luckily, I was only there for 2 nights before being transferred to the mother and baby unit, but I will say they were the worst 2 nights of my life. My psychosis was I was at the height of it. I remember sitting on the corner of my bed. I was sobbing and crying and saying that I'd ruined everything for everyone, because I thought I had triggered the apocalypse and it was going to be the end of the world, and this was it. Evil had won, and I'd failed, and I'd doomed the whole of humanity. But at the time, it feels so real, and obviously, it wasn't the end of the world. I remember speaking to my husband on the phone that evening, and he told me that he was going to meet me the next morning at the hospital, and he was bringing our baby. And I got there, and the paranoid thoughts continued. I thought the doctors were fake, the nurses were fake, all the other patients had gone home on leave, and that kind of all fed into my paranoia that this was all fake and a setup. But they diagnosed me, got me started on the right medication. I had the right support and help, and I actually responded really well to the medication. And I would describe it as though I'd woken up from a really, really terrible nightmare, and then I had this realization that everything that I'd been thinking, feeling, sensing, everything that had happened was down to me being really, really unwell. And that's when I started reading up about postpartum psychosis. And that's how I actually found APP. I met one of their volunteers on the mother and baby unit, and she told me about her own experience of postpartum psychosis, and that was the turning point for me. Listening to someone describe exactly what I had experienced and gone through was such a huge moment in my recovery, and for the first time I felt there's someone who understands what I've been through. They've been through it. Slowly I began to realise there are so many other women out there who have been through this, who are there to support me. And then when I was asked if I would like to become a peer support worker, I didn't hesitate. shortly after, I was asked to work on the Diverse Communities project, looking at encouraging more women from Black and Asian backgrounds to come forward and access help and support. But actually, a lot of the core work that I do is just simply about raising awareness. So mental health is not spoken about as much in these communities as it should be. People do talk about depression, anxiety, baby blues, but they don't talk about postpartum psychosis. I now host a monthly Muslim Mums Cafe group, and the women feedback that because women of faith and no faith experiences quite commonly is there's a link to religious beliefs and faith, so that ability to talk to God, see or hear angels, and the whole scary side of things and evil spirits and having to protect themselves. Have been in a space where somebody understands your faith background and be able to talk about those things openly without having to explain what those things are. I just want to say that I was really lucky that my family explored both spiritual healing as well as getting me the medical help that I needed. And that's my story. I hope you found it helpful, and I hope you find the rest of the webinar today helpful as well. Bye-bye.
Okay, so I'm Rob Cantwell. I'm going to talk to you today after those very powerful testimonies about the confidential inquiries into maternal deaths and what they tell us about the deaths of women over the course of the inquiries from mental illness and what lessons we can learn to improve their care. The confidential inquiries into maternal deaths have reported on all deaths of women in pregnancy and up to a year postnatally since the 1950s. But since around about the mid-1990s, have also reported in detail about deaths due to mental health causes. And you can see here the progression. I've just picked out three of the covers of inquiries dating initially from the 90s and moving on, where the title of the inquiries has changed from Why Mothers Die to a focus on saving mothers' lives and what we can do and what we can learn to make changes, to more recently Saving Lives, Improving Care. So that we're actually looking at the quality of the care that women receive as well. And one of the strengths of the inquiries over the time is that thankfully the numbers of women who die are low. What we can learn from them is that we know not simply the numbers, but we also know the stories, the individual accounts of the women's care and the quality of that care. And so we can begin to see themes that run together that help us understand how we can improve care for women. This is from the most recent inquiry, which came out just a couple of months ago and covers the years 21 to 23. And one of the consistent messages that we know from the inquiries to date is that maternal suicide remains one of the leading causes of maternal death. And you can see here in this most recent inquiry, it was the fourth most common cause during pregnancy and in the 6 weeks after delivery. But then from that period on to the end of the first postnatal year, it's the commonest cause of death. And you can see the numbers there below. And these are numbers over 3 years. But you can see that in that over a 3-year period, around 88 women died by suicide that were reported to the inquiry. And then you can see also, and I'm not going to talk about this today, we're focusing on postpartum psychosis, but also you can see a significant number of women who died from mental health causes related to substance misuse as well. And it's important to keep in mind the wider causes as well of deaths due to psychiatric illness or psychiatric disorders. You can see here something on the rates looking right back from 2000, from the start of the millennium up to the most recent report. And what you can pick from that there, the rate of deaths by suicide in this most recent report just out is 4.06 per 100,000 maternities. You can see that overall what we have not tragically succeeded in doing is reducing the rate of death due to suicide. But we have learned many, many lessons that improve the quality of our care. And we're still chasing, however, that elusive goal of reducing the absolute numbers of women who die by suicide in the inquiry. But we've learned a lot of different lessons, and I'll come on to those in a moment. But I just want to describe a little more to you, first of all, about the pattern of deaths for these women and what we know about the timing and the mode of death for the women who died by suicide. You can see, first of all, in the top bar chart there, how most women who die by suicide die in the postnatal period. Although there is a rise in the time just leading up to childbirth. In the lower table, you can see how these women died, and this is one of the most shocking but consistent messages that we see since we've looked in detail at deaths of women in the inquiries for mental health causes. And that's that for the women who die by suicide, they tend to use violent methods. And they use violent methods more commonly, that's methods other than overdosing. So they use methods like this more commonly than women do at other times who die by suicide in their lives, and more commonly than men who die by suicide. And that's unusual because in general, men are more likely to use violent methods to kill themselves. And what that tells us, I think, is two important messages. The first is that these women are suffering from significant mental illness at the time of their death. And the second is that they're very clear about the outcome as a consequence of that mental illness. The other thing that we've tried to look at from time to time in the inquiries is looking back over the stories of these women who die and their case notes to try and understand their underlying psychiatric diagnosis. And you can see here from the previous inquiry in 2021 that we had sufficient information. We're always doing this retrospectively, so it's a little difficult, but we had sufficient information to be able to make a diagnosis for a significant number of these women. And you can see there that the commonest diagnosis is of depressive disorder, over half of the women. But you can see that just over a quarter, somewhere between a quarter and a third of women had some form of psychotic illness. And if we look at the next slide, you can see here in this bar chart, this is showing you the proportion of women who had a psychotic illness who, as a proportion of all women with psychiatric diagnosis reported in the inquiry. And you can see that that number varies from around about 1 in 5 to as high as 1 in 3 or even slightly higher than that over the course of the inquiry. So we see consistently that the women with psychotic illnesses make up a significant proportion of the total number of women who do die by suicide. And this is something, again, from that previous inquiry that around highest level of care. So who were these women being looked after at the time of their deaths? And you can see here, this is sort of a ranked order of care. So a small number, almost 1 in 10 women had received mother and baby unit care, the highest level of inpatient specialist care at the time of their deaths. But you can see that there are a couple of other groups that really stick out in this bar chart. There's a group around 16% of the women whose highest level of care was from crisis or liaison or home treatment teams. And we know that sometimes non-specialist teams aren't aware of the particular distinctive patterns of the onset and course of severe perinatal mental illness, and sometimes don't necessarily place the level of urgency on the need to treat these conditions or to recognize the rapid changes that can happen, a rapid deterioration in mental state that can happen in the course of the illnesses. We also can see there that 1 in 3 women, for them, their highest level of care was universal services. And some of these women may have benefited from referring on. For some of them, there may be no warning signs and their deaths may have been completely unexpected, but there will be a proportion of those women who may have benefited from more specialist assessment and treatment after that. So we're not necessarily still as good as we could be at making sure that we're treating these conditions as psychiatric emergencies that need early, prompt referral into specialist care. So coming on to some of the recommendations and some of the lessons, and this is going back to the report from 10 years ago, where we looked at what might be indicators for women who are being assessed of suicide risk in the perinatal period. And these aren't all the indicators, obviously, but they're some of the main messages that came through. So one of the the first and most important things to look out for is a change in mental state, something that is different, something that is unusual for this woman. So new symptoms coming on or a rapid change in mental state. The second major sort of red flag that came out was newer or persistent violent thoughts of self-harm. Where people either acted to harm themselves or talked of harming themselves. And the third point is that new and persistent expressions of incompetence as a mother or estrangement from the infant, women who felt that they weren't themselves being good enough mothers, often in the face of all evidence to the contrary. And you can see here a woman, so this is a lesson around that symptom pattern progression. You can read there a woman who saw really rapid deterioration in her mental state. And although she had previous lowered mood in a postnatal period, there was a very different qualitative picture to this deterioration occurring on this occasion. And here also a message around that estrangement from the infant, a woman who, despite all evidence to the contrary, she was doing her best to look after her baby, but developed profound beliefs, probably in the context of a psychotic illness, that she wasn't any good for her baby as a mother, and she died within a relatively short period of time. We also looked in a subsequent inquiry about risks of recurrence. So for those women who do have a major mental illness or have had a previous postpartum psychosis, what's their risk? We know that we should be looking out for any woman with a past history of any psychotic disorder, whether that's a disorder like schizophrenia, bipolar disorder, or any other form of psychosis, and treating those women as at high risk. We should be closely monitoring women if there's a family history or if there's any current mood disorder. And we should be taking that pattern sometimes, if there is a family history, that pattern of recurrence that we've seen in other members of the family or in a previous episode of illness in the woman herself, as indicators of a predictor of future patterns of occurrence and recurrence. Another message I just wanted to bring to your attention as we're finishing up is just around some of the challenges we have, given that we now have many services. We've seen a rapid expansion of special services for perinatal mental illness. And sometimes that can lead to confusion in terms of referral pathways. And these are two examples of women whose referral pathway was confused to where people thought she had already been referred to an appropriate service, but in fact she hadn't. And we know that the pathways have become more complicated, and it's really important for all health professionals that they're aware exactly who they should be referring women with what problems to in their local area. And these are examples of some of the responses in rare cases, but nonetheless responses that we've seen in the inquiries from perinatal mental health services who've sometimes put barriers in the way of responding urgently to what we should regard as a psychiatric emergency. I'll just bring you up to date with the latest inquiry and just talk about some of the themes. I did say, obviously, there are many other lessons to be learned from these inquiries, not just around women with psychosis, or not only around women with psychosis. And there are lessons from the most recent inquiry just out around loss, being particularly attentive to women who've experienced either a pregnancy or a neonatal loss, or who've lost their children into care as being a particularly vulnerable time for them. We're seeing increasing numbers of women with complex social factors coming into who die by suicide, and where there are multiple, where the response needs to reflect that complexity of the presentation, and where perinatal mental health specialist services need to enhance their role as leaders and coordinators of care. And lastly, I'll just leave you with some of the questions that certainly have gone through my mind as a clinician in terms of risk evaluation, thinking, is this different for this woman at this time? Particularly, so looking at her and her knowledge of her and listening to relatives and hearing what they tell us about her. Do people around her have a good understanding of what the indicators are of severe perinatal mental illness, what the symptoms are, and how to respond, what the pathways then into care are, and how we communicated that through for the range of professionals who are involved with the woman's care. And again, thinking about the family, there are many lessons in the inquiries around engaging with families, listening to them, hearing what they have to tell us about their concerns and their risks. I'm going to stop now, and I'm going to pass you on to Sally.
Thank you, Rock, and good afternoon, everyone. My name is Sally, and I'm APP's training coordinator, and I have a background in academia. So I'm going to talk to you very briefly about what we know through our work at APP about postpartum psychosis. So PP is a severe, frightening postnatal mental illness. It has a rapid onset and is therefore considered a medical emergency. So for this reason, if it's suspected, help should be sought immediately. However, with the right treatment and support, we know that people can make a recovery. So those with a history of severe mental illness are at a higher risk of developing PP, and Ian's going to talk about that more later. But we know that approximately half of those who develop PP have no history of serious mental illness. So it affects those giving birth from all backgrounds, classes, cultures, education levels equally, which is why it's so vital that all frontline health professionals know about it and know what to do. So PP occurs in about 1 to 2 in 1,000 people who give birth. So whilst it's not as common as other perinatal mental illnesses, as far as serious life-threatening complications go of childbirth, PP is one of the most common. So APP's YouGov poll in 2021 found that 39% of the general population heard about PP. So although awareness has increased over the last 10 years, which is good, it is much lower than other maternal illnesses. And also we found that 6% of expectant parents had heard about PP in their antenatal classes. So using APP's existing resources and data from our antenatal campaign and survey, we've developed some antenatal toolkits to help support professionals and expectant parents. We know in APP that lack of awareness has led to delays in spotting the signs and symptoms, lots of trauma, and for some, as we've already heard today, loss of life. So by raising awareness and talking about PP, we can help to save lives. So the signs and symptoms of postpartum psychosis can vary amongst lots of individuals. Typically, they can come on quite quickly after childbirth. However, in some cases, it can happen later on as well. So they can include mixed mood, which can change very quickly. So, for example, feeling elated, frightened, tearful, confused, racing thoughts, unable to sleep, and unusual beliefs or hallucinations. So that's seeing, hearing, or sensing things that others can't. We know that recognising these early signs can actually save lives. So in the middle of the screen, you can see here, based on a study that we conducted a few years ago, the most frequently reported symptoms were feeling excited, elated, racing thoughts, busy mind, increased energy, and confusion. So in most cases, there are early signs and symptoms before the full-blown delusions and hallucinations. They are difficult to spot, but what I want to point out, which Rock has already talked about, is what is considered out of the ordinary for that person, which is why family and friends are so important. So these symptoms should be monitored, and if we spot them, we need to get help quickly. So I'm just going to talk a little bit about that help, what urgent referral should look like. So we do acknowledge that there are grey areas in terms of spotting these signs and symptoms, and some people can present very differently, and some people can even mask the symptoms for a very long time. But if you feel something isn't quite right, then do seek help and know where to refer to. So NICE and RC Psych state that if PP is suspected, a woman should be assessed urgently, ideally within 4 hours, by a perinatal crisis team if they're at home, or psychiatric liaison team if they're at A&E or maternity. So what are the local referrals pathways in your area? Do you know who the perinatal team are? Do you know where the mother and baby unit teams are? There's a web address here that just has a list of all the perinatal teams and MBU teams in England. So that might help you with that as well. And just a couple of key things Rock has already touched upon today. Just remembering that crisis teams sometimes have slightly different referral criteria than the postpartum period. So their aim is to keep people well and out of hospital, whereas the gold standard treatment for PP is to be admitted to a specialist inpatient unit. Also, if it is out of our hours, it isn't ideal. It's not the best pathway, but messages to families should be to call 999, which potentially could involve ambulance, A&E and police. But it's important to make sure that the woman and children are safe and that families aren't left to supervise. So treatment and management should ideally include admission to a specialist mother and baby unit, alongside lots of other interventions like psychological and peer support. So mother and baby units are life-saving inpatient units with a specialist team who treat, care and support mother and baby together. So we have data from APP surveys looking at recovery and outcomes. And you can see here in the middle, we have the care outcomes in the middle, and positively, these outcomes have actually increased overall in the UK since 2010. So things like feelings of safety, feeling informed about the illness, confidence in the staff, and support with recovery have all increased, depicted by the pink and blue lines here in the figure. However, in all the recovery and care outcomes, those that were treated in a mother and baby unit have significantly better outcomes than those treated in general units. And at APP, we see daily the benefits of MBU care, and conversely, the trauma that happens when people don't go to mother and baby units or are treated at home. We know that recovery from postpartum psychosis can be complex. It's a very individual process, and unfortunately, we don't have enough time to cover everything today. But I just wanted to point out a few key points, really. Recovery can take a very long time, anywhere between 6 months and 3 years plus. The initial psychosis can be followed by periods of depression, anxiety, low confidence, self-stigma and guilt. So often people will still be recovering when they're discharged back into primary care from secondary services. Importantly, APP also found that over 50% of people who experience PP will have some kind of suicidal thoughts in the year after being discharged from hospital. So those feelings and thoughts are very complex and they're very individual, but those who have suicidal thoughts and lose their life to PP don't always have the typical risk factors that have been identified in other periods of life. And we also need to acknowledge that there's a risk in the acute phases of psychosis due to the mania, the hallucinations and the detachment from reality, but also in the long-term recovery in the more depressive phase of the illness. We know the impact of postpartum psychosis can last a long time, so it takes time to come to terms with what's happened. So we need to think about your role in the acute phases. So for example, identifying signs and symptoms and getting help quickly, but also what your role might look like in the lifespan of someone who's experienced PP. We also know that PP can have a huge impact on dads, co-parents and the wider family. Families often state that it's the most devastating time of their lives. So this slide highlights the importance of peer support. We know that it offers hope in a very dark time. We also know that 46% of people who use APP's peer support service said they might not be here today without it. And I am one of those. So when I was ill in 2015, my psychosis came on very quickly the day I gave birth. My delusions involved me having harmed my baby, and I thought there was no way I was ever going to face anyone or carry on. This was 100% my reality. It was very scary and frightening, and the only thing that kept me safe at the time was being admitted to a general psychiatric unit. It was incredibly traumatic, and I was separated from my daughter. I had amazing health professionals advocating for me, but unfortunately at the time there were no specialists in postpartum psychosis, and I didn't access an MBU or mother and baby unit. So I had ongoing psychosis and severe depression. So alongside the psychosis, I had constant impulsive and suicidal thoughts, and it was a battle to survive every day. So for me, talking about these thoughts really helped at the time. It was like a tiny release of pressure for a few moments. After 10 months of struggling, I was signposted to the information and life-saving treatment that I needed, which for me was ECT or electroconvulsive therapy. So it took me a long time to recover, but I'm so far from where I was then. I know I'm fortunate to be sitting here presenting to you today. My story could have easily been very different. So we need to make sure that we work together so that all frontline health professionals know about postpartum psychosis, we know where to get help. We know that recovery can take a long time, and importantly, we need to offer hope that things will get better. So thank you for listening, and I'm just going to hand you over to Professor Ian Jones now.
Huge thanks, Sally. Let me just share my slides. Okay, somebody I'm sure will let me know if you can't see those. Right, thank you, Sally. I'm going to add on to that fantastic talk, addressing this particular issue of which women are at high risk. I'm going to say something at the beginning about why understanding who's at high risk is so important, and give you what I think are perhaps the three most important markers of high risk. And then at the end, I'm going to say something very briefly about how we should manage those at high risk. So why is it important to know about who is at high risk? I think it helps us in our preconception advice we give to women to help them make some of the most difficult decisions, I think, that women with severe mental illness have to make, particularly around medication, for example, continuing, stopping, switching medication in pregnancy. And as services, I think it also will help us identify those women who need and would benefit from close monitoring from services through pregnancy and into the postpartum period. And one really important point, I think, is that it gives us an unrivaled opportunity to work preventatively. Nowhere else in mental health, nowhere else in psychiatry do we have the situation where we have somebody who is maybe 100% well, who we know has a 50% or more risk of becoming severely ill in a few-week period. But as we go through some of those markers of high risk, it's important to remember what Sally's pointed out already, that at least 50% of postpartum episodes are out of the blue. There's no real indication that the women were at high risk. Okay, another reason why I think this is really important is that women themselves tell us that they find it difficult to get the information that they need. This is work from the fantastic Claire Dolman, woman with lived experience of PP and trustee of APP, who in this amazing qualitative study she did with women with bipolar disorder, what came out of that very strongly was that women found it difficult to get the information for services. It's something that in clinical services we need to do better. So what about those markers of high risk then? Let's think about important marker number one, which is a past history of severe mental illness, and in particular, a history of bipolar disorder. It's never been better illustrated by this study from Tree-Monk Olson, which looked at what happens in the year following delivery to women with a range of previous psychiatric diagnosis, and shows the top line, the red line, shows that women with bipolar disorder, previous bipolar episode, around 20% of them have an admission with in a severe recurrence in that first postpartum month. The other thing that this slide shows us is that women with a history of other psychotic illnesses, schizophrenia in this case, or schizophrenia-like illnesses, the perinatal period is a difficult transition. Yeah, but if you see that blue line there, which represents what happens to women with schizophrenia-like illnesses, that those admissions are spread out much more evenly in that first postpartum year. You don't see that great increased risk of postpartum psychosis immediately after delivery. The other thing is if the risk is increased in women with bipolar disorder, it's women with the more severe forms of bipolar disorder, so-called bipolar 1 disorders, that are at highest risk. This is work from our research from the Bipolar Disorder Research Network, where first author was the wonderful colleague Ariana Di Floria, that showed that there was a high risk of recurrence in pregnancy or the postpartum period across the mood disorder spectrum, whether that was recurrent major depression or bipolar disorder. But it really, if we look at the risk of postpartum psychosis, it was women with bipolar disorder, bipolar 1 disorder, that were at highest risk. Second important marker, and this is probably the strongest predictor that we know, is that women who have a previous history of postpartum psychosis are at very high risk. Yeah, this is work again from our bipolar disorder research network, where we looked at women who we had data on more than one pregnancies, and what we were able to demonstrate very robustly and strongly was that a previous postpartum psychosis predicted a postpartum psychosis recurrence in future pregnancies. Odds ratio of 7.5 here, very strong finding. So over and above that history of bipolar disorder might be a marker of high risk, what happened in that first pregnancy, and from this flowchart, we can see that if you look for women with a bipolar 1 disorder who'd had a postpartum psychosis, they were at a 45% chance of a recurrence in future pregnancies. But women with bipolar disorder who hadn't experienced an episode in their first pregnancies were at a much lower risk, around a 1% chance of postpartum psychosis in future pregnancies. So bipolar disorder, severe mental illness, bipolar disorder particularly, and previous postpartum psychosis is important. And then the final high-risk marker I'm going to talk about briefly is family history. Now, certainly a family history of postpartum psychosis increases your risk, but because the risk is low, around 1 in 1,000 in the general population, the absolute risk remains low. That translates into something like, from the research evidence we have, about 1 to 3% of women with a family history have a history of personal, without a personal psychiatric history, having a risk of PP. What's really important to note, though, is that for women with a personal history of bipolar disorder, that family history of postpartum psychosis may double risk and is really important. So my final slide then, hoping to catch up a bit of time. How do we manage those women at risk? I think it's really important for all of us that look after women in pregnancy in the postpartum period to be aware of these risk factors, to identify those women in those high-risk groups and to refer them into a specialist perinatal team. I think discussions about medication are going to be really important here, and those decisions must be collaborative based on an assessment of her individual women and her history and treatment response, needing to consider the risks and benefits of all options, bearing in mind that nothing is risk-free, but for some women, continuing medication may be the best option. But a really important point to make, and maybe we can come back to this in the discussion podcast, is that it's not just about medication, it's about identification of risk, about close monitoring, and about psychological and social management as well. And with that, I'll finish and hand on to Alison.
Good afternoon, everyone. Thank you, Ian. Okay, so I'm here to give you 10 top tips. I thought I've got 10 minutes, so I'm going to give you 10 top tips in suicide prevention. So I'll very much try to keep to my time. So first of all is remembering that anyone can be at risk. As you've heard from Ian, this is quite a unique area in that you do have an unrivaled opportunity for prevention in this particular circumstance. At Pete's Dragons here in Devon, we operate the real-time suicide surveillance system. So we monitor all deaths that happen across the county. And this is just an illustrative slide on how we sort of report back to our partner agencies about all the risk factors involved. And they're so important from a strategic level, from a prevention level, and from an opportunity to make change. But when working one-to-one with people, sometimes they can make us be a disadvantage because we might be looking for particular things. And I always reiterate to people, when you're working one-on-one, anyone can be at risk. Forget about the risk factors in that situation, because every single person, all of us, everybody on here today, and given the right set of unique circumstances, which are unique to us as individuals, we can all be at risk of suicide. And number two, always ask the question. Some of you may be familiar with something that happened a few years ago in Detroit, where a particular healthcare company decided that they would ask every single person that entered their service whether they were having thoughts of suicide, whether they came in because they had, cut their finger or had a bad back. Regardless, everybody was asked the question, and they achieved 0 suicide across their service, and all the people
people that they, were their patients. There were some criticisms around this, and if you want to look into it, it's all there for you. But the numbers can't be argued with. So if you have any intuitive feeling, or you just feel that you need to ask the question, or ask everybody the question, you're not going to miss anything. But how you ask the question matters, which is number 3. And even if it is part of a checklist that you use, which it so often is when you're looking, you're providing care for people, always try to make eye contact when you ask that question. It's such an important question to ask, and the answer is so important to the person that you're asking. It really deserves you to give them that reassurance that you are the right person. They will be looking for the right person to help them, or the part of them that wants to live will be looking for that person. So making eye contact, giving them that reassurance that you want to hear the answer. Again, another study, I believe it was Exeter University, recorded professionals asking that question, and found that sometimes, it was done very much head down, and you could almost see in the videos that the person wanted to say yes, but because they were being asked by someone who was just moving a pen and had their head down, they couldn't quite get the yes out, so it was a missed opportunity, and also even sometimes there was a kind of nodding no of the head when they're asking the question, "Are you having thoughts of suicide?" Which, an indication that the professional wanted a no answer. So how you ask that question matters, and maybe next time you ask it, just think about your body language and notice how you do it, and maybe do some work on that if you feel that you need to. Number 4. So this is about listening. So imagining that you've asked the question and someone has said, yes, or I think I am, or this is what I'm thinking. Ask what has led them to feeling like this. The listening step of any suicide intervention is absolutely crucial, and it doesn't have to take lots and lots of time. You don't even have to understand what is being said to you about what someone is feeling has led them to feeling suicidal. What you're actually trying to do is help them to apply perspective and logic to the thoughts that they are having. Sometimes that's possible, but sometimes that's not possible. But just feeling listened to. We've already heard from Sally that just being able to talk about the thoughts of suicide and how they are for them and how they're appearing and what other thoughts they're having, hugely beneficial. So you don't need to understand, it doesn't need to make sense, but you need to give someone the space in order to have those beneficial conversations around it. And a great question to ask is, what's led you to feeling, what do you feel has led you to feel like this right now? And asking about their suicide thoughts, sometimes that can be the elephant in the room, and it can be the bit that's missed. So you've given them the opportunity to talk about what they feel has led them to feeling like this and why they're having those thoughts, how they're feeling about themselves. We heard earlier about maybe they're having persistent thoughts of being an incompetent parent, etc. Those are the sorts of things you're likely to hear at that stage. But then asking, how do those thoughts present? When are they most common? How do they come to you? Are they telling you to do anything particular? Do you have a plan? Again, it gives them the feeling that you are the right person to help them. So builds that therapeutic relationship, which is really important. Builds trust, gives them confidence in you, but also normalizes all of this. Here's someone that's willing to talk about all this stuff that's going on in my mind. How reassuring, and what a gift for anyone who is experiencing that. And then noticing their language when you're in the listening step, when you've asked them what's led them to this, or you're asking about how the thoughts appear, noticing their language. You're looking out for anything that is a but, or an I wish, or maybe, I hope, I have hoped, or this is how I feel right now. Listening out for anything that they love or they care about, or any future aspirations that they may have had. Because what you're going to want to do is reflect those back. When we are distressed, or we're experiencing suicide thoughts and have PP, or experiencing that, we won't necessarily hear what we are saying. So to have someone reflecting back to them, oh, I heard there that you hope this for the future, or I heard you say but, which makes me feel that you're really uncertain about this. And I can hear how much you care about and you love and you want to protect this person. So just reflecting those kind of positive things back, or any element of confusion or uncertainty around these suicide thoughts, again, really beneficial for the person experiencing that to hear that back, like, oh, maybe I'm not sure, maybe this isn't the right thing to do. So really important to do that. And validating and normalizing. This doesn't have to make sense to us. In fact, it probably won't. But just normalizing what they're experiencing in all the circumstances with what you are experiencing, this is normal. I can't tell you enough how powerful it is for someone who has experienced this to hear that in all the circumstances, this is actually normal. It's enormous for them, and gives them a perspective of, okay, so other people have experienced this. This is a normal part of what I'm going through. Maybe it won't last forever. So normalizing, really, really important, but also validating how they feel, not trying to correct them. No, you are a good mother. No, you will be a good mother. That's not how they see the world right now. And it's crucial that we get alongside someone and try and see the world how they see it, rather than try and correct or fix, which can feel slightly judgmental. So allowing them to say all the things, and, I'm sorry you feel like that, or that sounds really difficult for you, but getting alongside them rather than opposing them, and trying to correct thoughts at this stage. And then once you've validated and been through that stage, ask them to agree to safety for now. And it's just for now, because forever is too big and too far and too uncertain for somebody. But asking someone to just agree to staying safe for now, it seems achievable for most people, particularly if you've reflected back some of that language where they've demonstrated themselves that they're not certain, or they've got future aspirations. So just asking them to stay safe for now, a nice bite-sized chunk for them to take a step forward. And then number 9 is safety planning. I haven't got time to take you through a safety plan, but and other safety plans are available. But personally, I use the stayingsafe.net safety plan. It's downloadable onto a smart device, any smart device, or you can print off paper copies for anyone who would prefer that. It's guided, so it's got sort of 7 sections, what things that you can do right now. So in those crisis moments where the suicide thoughts are really strong, somebody has pre-made it, or you've made it together on their smart device, all they've got to do is click a button, it opens up, and it gives them suggestions of things that they can do to disrupt those suicide thoughts. They can write messages to themselves when they're feeling slightly better. They can write little messages to themselves saying, those thoughts are not real. Remember, I love you. Remember, other people love you. So that it's all there just to open up on the phone, and get them through those moments. Also with pre-programmed telephone numbers that they can put in, or national crisis lines, just so that they don't have to think about anything. It's just laid out on their smart device when they need it. So I'd highly recommend that you have a good look at that. And wouldn't it be lovely if, everybody had a safety plan, because we never know and everyone's at risk. But wouldn't it be really lovely if all expecting mothers had a safety plan just in case? So it was all pre-written and ready to go. And then number 10, should say number 10, says number 9, but it is number 10. Reapply as necessary. It is not a failure if you have to do this again with somebody over and over again. It's a success every single time, because you've got the opportunity to do it again. So I speak to many professionals that feel as though they're not doing well enough because they're having to keep reapplying this to an individual. That's fantastic. That individual trusts you. You're getting it right each time. You're doing your very best, and they keep coming back, and they're still here. So reapplying is an absolute success, and always believe that. Hopefully I've caught up on all the time for you, and I am going to now hand back to Jess.
Thanks, Alison. A massive thank you to all today's speakers for sharing their time, passion, and their knowledge to make birth safer for new families. Whatever your role in healthcare, we'd be delighted if you could join us in helping to increase awareness of postpartum psychosis in whatever ways you can. If you need resources to train your team or have ideas of ways you can help, just get in touch with us. You can also sign up for APP newsletters. The link's in the chat. We know we can only just scratch the surface of this topic, so to access more in-depth training, visit the training section of the APP website or get in touch with Sally at training@app-network.org. Webinar attendees will receive a discount voucher to take part in APP's workforce training after the seminar. There are also other great resources on suicide prevention from stayingsafe.net, as Alison's mentioned. You can donate to support APP's work using the link in the chat. And this week, before the 15th of October, all donations will be doubled by the Big Give. We've also got a whole host of challenge events, runs, walks, cycles, skydives, bake sales you can get involved in, either as an individual or a health professional team. Before you go, we'd really appreciate if you could just spend a couple of minutes filling in the feedback form to help us develop the webinars to meet your needs. There's a link in the chat now, so I hope you can just spend a couple of minutes doing that. Thank you so much for spending your lunchtime with us, and enjoy the rest of your day.